If you have ever wondered what it's like to work in the emergency department, maybe you are a new grad and you're considering the ER, or maybe you're a nurse already and you're wondering what it's like to work in the emergency room, this is my pretty inclusive list of the most commonly used medications in the ER. So just keep watching, this video is for you.
Say what you wanna say to me now. I wanna wake up with you in the morning. Show me there's nothing fake to me now. I wanna wake up with you in the morning.
Okay, there is no particular order in which I'm going to be rambling off these different medications. These are just, in my opinion, the most commonly used meds that we give pretty routinely in the ER, and I think that all ER nurses should be familiar with these meds. So let's just start out with the pain med category first and foremost. Can you guys see the ring light in my glasses? These must come off because I simply will not deal with that for the duration of this video. We very often, almost every single day, treat patients that are in acute distress or discomfort because of their pain. So some of these medications are the ones that you're going to see most commonly given out to help treat pain in the ER. The first one is a medication called ketorolac, aka Toradol. Toradol is given out in milligrams of 15 to 30 typically, and that usually comes out to about a milliliter of fluid in your syringe. Toradol is an NSAID, which means it is a non-steroidal anti-inflammatory medication. Let me tell you, this med works wonders for patients with kidney stones. So if you've got a patient coming in with left, right-sided, or bilateral flank pain, and you're anticipating that they have a kidney stone, check their allergies, and as long as they have no contraindications to Toradol, that med works amazing to treat kidney stones. Speaking of contraindications, there are a few that you want to be careful of with this med, aside from just a general allergy. This medication is not given for women who are breastfeeding. Most physicians will recommend that the Toradol in their system has at least been out of the system for about 24 to 48 hours if they are breastfeeding. The other contraindication is if they are pregnant. So pregnant women, of course, want to avoid this medication. Toradol is great because of its anti-inflammatory properties. So any injury that's causing an inflammatory response, it's going to kind of suppress that and help alleviate that patient's pain. Another thing to be mindful of with any NSAID drug, though, is that it can cause stomach ulcers or a tearing of the GI lining. So I once had a patient actually who, I don't even know how she got prescribed this dose, but she had taken about 5 unknown milligram pills of Toradol over the course of 72 hours. And so with that being said, she actually created a gastric ulcer in her stomach, and she noticed blood in her urine and in her stool. So be very mindful that if your patient had a gastric bypass surgery or any type of bariatric history, GI history, Toradol might not be the first line med for that patient to alleviate their pain. So always offer them, some alternative routes. Pain med number 2. Dilaudid. This one is given very routinely. A lot of patients will tell you, oh, nothing works for me, just give me that Dilaudid. And you have to let them know, like, hey, we're gonna talk to the physician first and then we'll see what he or she wants to do. Dilaudid is very effective for pain. However, it will affect the patient's vasculature. So make sure that this patient does not have a low blood pressure prior to giving this med. You're gonna wanna check their pressure. Make sure that their systolic is at the very least 100 and their diastolic is no less than 60 to 70. Excuse me. That's the biggest thing to look for when giving Dilaudid, is that you do not want to drop that patient's blood pressure too low, because again, it will affect their blood pressure too. The next pain management med that you are going to want to get ultra familiar with in the ER is, drumroll please, opioids. Opioids such as morphine and fentanyl are used super commonly and very routine in the ER. Let's start with morphine first. Morphine is an opioid. It acts on the pain receptors of the patient. Typically, it's given in 2 to 4 milligrams. Oftentimes, it doesn't even touch the patient, you guys. Like, you'll start with 2 milligrams usually. You're going to notice that for most people, depending on their size, height, weight, etc., it's really not going to take their pain away, and they're probably going to be asking you for some more within the hour. Generally, when that happens, the physicians are going to order the other 2, and you'll want to space that out accordingly, but you can give that other half, and noticeably, it probably won't do a whole lot. You don't want to give too much of morphine, and you want to give it very slowly. You want to make sure that that patient is still breathing adequately. Just remember that morphine can sometimes make patients very nauseous when you're administering it, so push that very, very slowly into their IV. The next common pain med in the ER is fentanyl. Fentanyl is usually given in micrograms. It'll be anywhere from like 75 to 100. Very similar to morphine, it doesn't often take the patient's pain away. You will often see these 2 medications given concurrently. So it's not uncommon to be giving any patient in the ER that's experiencing a lot of pain, fentanyl and morphine together. So just understand that that is very normal. Fentanyl is going to have a sedative effect a little bit, and that is the goal. So just make sure that you're monitoring their respiratory rate as well, making sure that it doesn't fall. Anytime you're giving a medication like this, such as an opioid, you are going to want to be mindful of the reversal agent. So the reversal agent for opioids is naloxone, aka Narcan. Narcan is also given very routinely in the ER. You can give it intranasally. I've given it actually most commonly through the IV, and it is very, very effective if your patient has either accidentally or intentionally taken an opioid. You will have patients sometimes in the ER wake up after your administration of Narcan being very combative, very confused, sometimes very angry. Just understand that this is a normal response sometimes to the medication. It does happen, and sometimes your patient may even lie to you and tell you that they have no idea what happened, and they might, deny whatever drug use they had used prior to you administering that med, and that is usually coming from a place of fear because they don't want to get in any trouble. They think that they will be in trouble. So it's just important for you to know that any legal implications are not of a concern at this moment, and that you're just there to make sure that the patient is alive, healthy, and well. But don't let them lie to you. You can very kindly explain that you are aware of the medication that they had taken that caused this overdose, whether accidental, whether intentional, because you gave a reversal agent to opioids, and it works. You can get Narcan nowadays over the counter, which is awesome. You can get it from local health departments. It's widely available everywhere. Unfortunately, that had to be the case because of the crisis that we experience all across the nation. So be familiar with how to use it in the ER and know that it's a life-saving med. The next common medication that is given in the ER is ondansetron, aka Zofran. Zofran is an anti-emetic. It is my hero medication because right now it's flu season and people are always coming in super nauseous and sometimes vomiting. So this med is great. You can take it sublingually, so underneath the tongue it will dissolve, which is great for kids. You can take it IV. Obviously it works fastest if it's given intravenously. Sometimes with Zofran, you can actually give it prophylactically to giving morphine. So if you know a patient's going to be getting morphine, you can give Zofran ahead of time just to make sure that you're preventing the onset of that nausea. Sometimes it can prolong the QRS interval, so just be mindful if they have a cardiac history, or you want to know, if they've taken any Zofran prior to you giving it in the ER, because if they exceed, the maximum dose, or if they take more than like 4 within 2 to 4 hours, that's not a good sign. You don't want to cause any cardiac arrhythmias or, put them at risk of harm in any way, shape, or form. But just be mindful of those things. But otherwise, it's a great anti-nausea, great anti-emetic medication given almost every single day in the ER, at least for me. Okay, glasses are coming back because I took notes. Also got the coffee, so now we're really ready. The next anti-emetic medication that I think you should know if working in the ER is metoclopramide. I think I'm gonna butcher the pronunciation, aka Reglan. So Reglan is given very routinely along with Zofran. It is often given to help suppress nausea. Sometimes you're gonna see different patients have different reactions. So maybe in some patients, Zofran will work and do the trick. Maybe in other patients, that's not really touching them, and you're gonna have to move on to Reglan. I will say that Reglan is given really commonly for migraine headaches. So anytime I have a patient that's coming in with severe migraine headaches that's starting to make them feel nauseous or even like messing with their vision a little bit, we usually dim the lights, give them some Reglan. You want to also be mindful with this medication, you need to push it slowly as well. I always have this saying that goes, when you don't know, go slow, right? So anytime you're hesitant about a med or you don't really know how it's going to make this patient react, maybe you're working with a kid, smaller blood volume, lower body weight, then you're going to want to push that medication very, very slowly. So just be mindful that they do affect different patients in different ways, and what works for one patient may not work for another. You're going to see that very commonly in the ER. So that's another one that you need to know. You know what, let me rewind a little bit. I forgot to mention something about Toradol when I was talking about the NSAID group. Toradol is nephrotoxic, so you want to make sure that you are checking that patient's kidney function as well as even potentially their liver function before you administer that medication. I forgot to throw that in there. All right, we're just going to keep it pushing through this list because as you can see, there's a lot. All right, let's move on to some cardiac meds, my absolute favorite. The first one I want to talk about, and arguably the most important, is epinephrine. So epi is given pretty routinely in the ER. We use it in code situations. We use it for patients in anaphylactic shock. Really any type of shock, epi can sometimes be beneficial as long as there are no contraindications, but most oftenly it's going to be used in allergic reactions or code situations. When it's used in a code situation, there are different ways to draw it up. I'm not going to spend a lot of time explaining that in this video. I think that is something that you should become really familiar with, learning, practicing, doing some muscle memory, and also studying the contraindications, so the reasons why we maybe would hold off on giving a patient epi. but most commonly just know that it's pretty much used for like true emergency. Oh my god, I need to stop doing that. True emergencies. Usually during a code, it's given like anywhere from 1 to 3 times before we end up moving on to a different life-saving medication. Usually second line is amiodarone. If epi fails, we go on to the next ones, but get familiar with epinephrine, know why we use it, know why we don't. Understand that it is going to compress or constrict the vessels in order to get that blood pressure up. So that's one of the reasons why we use it, but it's not the only reason. The next medication is diltiazem, aka cardizem. Cardizem is a calcium channel blocker commonly used in patients with atrial fibrillation, aka AFib. This is a cardiac dysrhythmia where basically the top chamber of your heart is quivering, and because of this, the patient is at risk for that rhythm turning into, if it's prolonged, it could turn into a more dangerous rhythm, which could end up being lethal or fatal. They're also at risk for stroke because of that quivering in the the top chamber, the blood starts to pool in the bottom chamber, and as it is pushing out blood, which the heart wants to do, the patient becomes at risk for expelling clots. So oftentimes you're going to see patients in AFib, atrial fibrillation, or AFib rapid RVR, which means rapid ventricular rate. You're going to see them on a blood thinning medication such as Eliquis, Plavix, some type of blood thinner, aspirin, but usually it's something a little bit higher than just your average aspirin. So with cardizem, these patients usually they're given a bolus of it at first, and if they are unresponsive to the bolus, then we might give a second dose and potentially even put them on a drip. These patients on a cardizem drip are likely going to be telemetry patients, so they're going to be admitted to the hospital and they are going to go straight up to the floors. If they are on multiple different meds like cardizem, fluids, there's other things being titrated, they may even potentially be an ICU patient, but that is generally what cardizem is used for. With patients in AFib rapid RVR, I've seen heart rates in like the 160s, 170s. Obviously that's very dangerous, right? You don't want someone at rest to have their heart beating that fast and working that hard. That's abnormal. We don't want them to stay there. So typically after giving diltiazem, I've seen patients get their heart rates down to 90 and then even as low as like 60. But then 10 minutes later, they might shoot right back up and be around like 120s, 130s. That is dangerous. That means that the medication is not working long term and we need to do some further investigation. They need to be on some other meds and potentially be admitted. Okay, my second anti-arrhythmic medication that can also be given for AFib rapid RVR, although definitely not as common as cardizem, is amiodarone. So like I mentioned earlier, amiodarone is a second line defense medication given in code situations. Studies and new research have actually shown that administering amiodarone first prior to epi in a code situation actually has turned out pretty negatively for the patient. Their chances and likelihood of surviving a code situation, of returning to ROSC, after a normal heart rate is restored, is not as high as opposed to giving epinephrine first. So that's just an interesting fact that I learned about amiodarone. I have seen some nurses give amiodarone in response to AFib RVR, but again, like I've never personally done it, very, very rare. But that's another one to get familiar with. It's going to be in your crash cart as well, along with your epi and then your other life-saving drugs. Straight up, I'm about to put myself into AFib RVR if I don't stop slamming this coffee. Are you guys having fun learning? Okay, let's keep going. Okay, the next medication is a benzodiazepine. This is lorazepam, aka Ativan. This is given very routinely if you are working in the psychiatric department or side of the emergency room. It is often given, unfortunately, to chemically restrain a patient after every other softer method has failed. That is not the only reason we give it though. It can be used for anti-anxiety, it can be used to help calm patients down. Sometimes we'll even give it for patients in respiratory distress or who are having trouble breathing and hyperventilating, because we need that patient to slow their respiratory rate. We need to calm them down. So oftentimes it's given for that. Again, I just think that that one's pretty routine and that you should be familiar with. Know that it is going to depress some of their hyperactive effects, and that is a good response. That's what we want to happen. Flumazenil, also known as Romazicon, is the antidote to benzodiazepines. So be familiar with Flumazenil. Know that Flumazenil is going to be your antidote to that. We also have patients who are going to come into the ER off of the streets. Maybe some of them are taking Xanax, other kind of depressive drugs, and Flumazenil is going to be the antidote for that. So you're going to want to just kind of be somewhat familiar with that one. So because too, a lot of these drugs that we're giving in the ER are high potent, very dangerous drugs, you kind of want to get familiar with the antidotes to them, because I'm not saying that you're going to make a mistake, but you might have patients who come in with overdoses. Again, especially if you're working in psych, it does happen quite a bit. So be familiar with the antidotes, know how to draw them up rather quickly, and be able to anticipate, what med's going to be needed for what condition. I think that could be very helpful to you as a new nurse in the ER. Okay, the next medication that I have on my list is adenosine. So adenosine is given for patients with a super high heart rate. So we call this supraventricular tachycardia. So their heart rate is either in, 180s, 200s, 230s, 240s. So the heart rate is extremely fast. This medication's half-life is very short. So what's going to happen when you're giving adenosine in the ER is you're going to hook your patient up, first things first, to the cardiac monitor. You're going to have the crash cart. You're going to have at least 2 other nurses and maybe even a tech in the room with you. You are going to hook them up to the pads, and what's going to happen is you're going to push that adenosine super fast through their IV. You are then going to follow it with also a super fast flush of normal saline. The half-life, again, super short. So you are going to slam this into the patient's IV, follow it up with some saline, and you are going to hope and pray that that heart rate is then restored back to normal as well as with a normal rhythm. I have done this quite a few times in the ER. It's never been unsuccessful, knock on wood, and it's not going to be. So basically what's happening when you're giving adenosine in the ER is you are chemically cardioverting the heart back to a normal rate and rhythm. Another thing to note about adenosine is that when you push this into the patient's IV, they are going to feel this sense of impending doom. I mean, they are going to look at you and tell you that they're dying. They're not, but they're going to feel like they are for a brief moment. You may even see their rhythm on the monitor turn to like a brief flat line, but then it's going to go back up. So don't panic. That's normal. That's supposed to happen. Yeah, they're going to feel like they're going to die, and they are going to look to you with fear in their eyes, but you have to reassure them that this is a normal response to the medication and that it will subside, and after they're going to feel so much better. And actually, it'll probably benefit you to tell them this in advance so that they can anticipate that feeling. I've always done that. It may scare them a little bit, but you have to reassure them that it's just normal. So adenosine, super cool drug that we give for supraventricular tachycardia. Again, it's something that you're gonna need to know, and it is in your crash cart with your other life-saving meds as well. Okay, and last but not least, the very last drug that I have for you here on this list is atropine. It is an anticholinergic med given for patients who are experiencing symptomatic bradycardia. Symptomatic bradycardia is essentially when the patient's heart rate is around 40 beats per minute or lower, and they're experiencing symptoms. So what does that look like? Typically, the patient is not going to be acting like themselves. They might be weak, fatigued, dizzy, unable to walk, unable to really even make comprehensible sounds. Something's going to be very clearly off with them. They might be sweating. They might tell you that they just don't feel right. Usually they're in a bit of a panic. So with symptomatic bradycardia, atropine is the first line med. You will give it intravenously, and it is going to act on the receptors and block certain pathways so that the heart rate goes back up to around 60 to 100 beats per minute. That is the goal. There's probably a ton of other meds I could mention, but for the sake of this video not being like 20 minutes long, this is kind of like my inclusive list of what I believe to be the most common meds that are used in the emergency room. If you have any questions, please leave a comment down below. Again, there's probably so much more that I could have listed, but these are the mainstay medications. So thank you so much for watching. If you are interested in more videos like this and more nursing related content, please like and subscribe and follow for more. Love you. Bye.